Okay, hi everyone. I'm your host, Nicholas Morris from the University of Maryland Shock Trauma Hospital, and this is the Neurocritical Care Society podcast. Today, as part of our Perspective series, we have the absolute honor of having Dr. Daniel Hanley on from Johns Hopkins University. Dr. Hanley is a graduate of Williams College and Cornell University Medical College. He's been a professor of neurology, neurosurgery, and anesthesiology, critical care medicine at the Johns Hopkins University School of Medicine since 1996. He has over 300 articles in peer-reviewed journals. He has received the Alexander Humboldt Research Prize for his accomplishments in brain injury research and has extensive clinical trial experience in the fields of stroke, hemorrhage, trauma, and brain infections. Most recently, he's really focused on intracerebral hemorrhage, and hopefully we'll talk about some of those pivotal studies later in our discussion. He was the principal investigator for the NIH-sponsored MISTY-3 and CLEAR-3 trials, investigating minimally invasive neurosurgical techniques to treat hemorrhagic stroke. Dr. Hanley, it's a real honor to have you on the podcast, and thanks for joining us.
Oh, Nick, it's wonderful to be here, and it's nice to, as an old person, to get to talk about the past.
Yeah, well, we're here to hear the stories because I don't think these stories have been told enough. So why don't you take us back and let's learn a little bit about the history of neurocritical care through your experience at Hopkins, which I think, as Alan Roper said previously on this podcast, might be the very first neuro ICU in the United States.
Right. Well, sure, we can talk about that. A couple of things in the introduction. You forgot that I'm a Brunswick High School, Brunswick, Maine dragon from a small town public high school. And there's no reason for you to know, but I went to medical school with Alan Roper, and he was my superior. He was a class ahead of me, and I think 2 or 3 years ahead in training and becoming a faculty member, because he did, I think, 2 years of medicine, and then moved into neurology. And I spent 3 years in medicine and then a neurology fellowship before I ever did my neurology residency. So I was a little retarded compared to, and to set the story straight, I actually, Alan had the first running neurology department unit, and I actually went to his training course the year I started the neurocritical care unit. So I would personally give him credit.
Okay.
Okay.
Well, he's giving you credit, so it seems like credit all around. So what was happening at Hopkins at the time where you decided this is something that needed to be done, or there was sort of a gap to fill?
Sure. I didn't really decide. I had an interest in this area because as Cornell Medical College students, both Alan and I grew up in an environment that had very good cardiac critical care, and there had been some leadership roles in that area in the 60s and 70s, and a good medical, infectious disease, pulmonary critical care capabilities that eventually morphed into that part of the Critical Care Medicine Society. So we were exposed to a lot of evolving general ICU care. And being an internist, I had capabilities in that area, and there were no credentialing of ICU physicians at the time. I did my neurology training at Johns Hopkins, and Johns Hopkins had a long interest in the ill neurologic, neurosurgical patients. Harvey Cushing, when he finished his residency at Hopkins, did what both surgically and medically trained newly minted specialists did at that time in the late 1800s, early 19th century. He went to Europe and saw what was going on in Britain, but particularly in France and Germany, which were probably ahead of Britain at that time in medicine. He took the sphygmomanometer, the blood pressure cuff, which was being used in general medicine, but also in the operating theater, and he brought it back to Johns Hopkins. And he thought it would be good to know what the blood pressure was of patients he was operating on. A little later at Hopkins, Walter Dandy, who Cushing trained but had a rivalry with, developed some of the invasive ventricular procedures, including ventriculostomy and ventricular puncture, which we now use in the neurocritical care unit and in other parts of neurosurgery. And he developed the idea that neurosurgical patients after an operation should be observed in a specialized unit. And I think Tom Bleck has talked a little bit about that. So there was a history of saying that patients with neurologic diseases needed specialty care for their whole body systems that had existed at Hopkins. Don Long was the chief of neurosurgery at the time that I started the unit. And it was not me, but others, the leaders of the institution, that said intensive care medicine is evolving as a specialty. Access to surgical intensive care was very limited for Dr. Long. He was allowed to have either one or two patients, but no more in the surgical intensive care unit. And access for Guy McCann and his vice chair, Chip Moses, was non-existent for neurologic critically ill patients. You had to call a consult from the medical intensive care unit, which was predominantly a pulmonary unit, in order to assess whether or not your patient required ventilation. And that wasn't a full assessment of critical care needs. They were joined by a pediatric cardiologist, Mark Rogers, who was the chairman of anesthesia. So he was triple boarded in pediatrics, cardiology, and anesthesia. And he was younger than either McCann or Don Long. And he wanted to evolve the anesthesia department into an anesthesia critical care medicine department. So it served his needs from a departmental strategy perspective to make that alliance. With that alliance, after a decade of trying to get a neurocritical care unit, Don Long was successful. He hired, the year before we started it, a former nurse educator from your institution, from shock trauma, Judith Ski Lauer, who was the head of a trauma and neurosurgery ICU at Washington Hospital Center to focus solely on neuro. And she and I and an anesthesiologist from who was a newly minted trainee from Mark Rogers' department, Cecil Burrell, started the Hopkins unit to address that need. And we started it on a temporary or conditional basis that neither the surgical intensive care unit leadership in the Department of Surgery or the medical intensive care unit leadership in the Department of Medicine saw a true need for this. They objected to our taking care of our own patients. And the hospital, in its wisdom, said, well, maybe it'll work, maybe it won't. So we'll try it for a year and see what happens. So they temporarily assigned us 4 beds in the step-down area of the surgical intensive care unit. And that was the first unit. We had 2 rooms. So Judith, or Ski Lauer, which is how she liked to be called, knew that in all ICUs, visual observation is critical. And I think as the neuro story evolves, it's even more critical in the neuro patient because one of the top skills is actual visual observation patient. So we took down the wall between the 2 rooms and just left the toilet area. So you had to cram usually 3 nurses, a couple of doctors, an attending physician, and then all the visiting services, probably in a 70 square foot area. And we thought that was pretty hard because you're constantly moving around someone else and trying not to push or treat them rudely. But it had the advantage that you could see all 4 patients at once. And that turned out to be a very helpful advantage. So that's how we started. And that's the beginning of my 40-year to life sentence as a attending physician at Johns Hopkins.
That's great. I'm sure there were some growing pains over the years. What were some of the major hurdles that you faced in developing things over maybe that first 5 to 10 year period?
Sure. Well, the biggest hurdle, I think, was there was no textbook, there was no plan, there was not much strategy other than neurology and neurosurgery patients were increasingly recognized as severely ill at some stages in their illness and needing of ICU support, and needing to have their ICU support integrated into their care at a whole body level, as opposed to the prior model of, well, this is a polio patient, they can't breathe, but all we have to do is put them on a ventilator or use an iron lung with negative pressure ventilation to meet their need. And we'll see if they survive, then we'll see what they look like. And that thought process, I think, was not wrong. I think it was pragmatic because there were very few primary disease-specific interventions for neurologic diseases.
Yeah. If you don't mind, maybe for some of our listeners who don't sort of know some of the history of one of our primary diseases, could you discuss how subarachnoid hemorrhage was managed in those early days and how that's evolved?
Sure.
It sounds, I mean, somewhat it's a similar story to polio.
Yeah. I think early on, subarachnoid hemorrhage was partially recognizable because in the pre-CT era, you didn't have an easy test for blood in the brain that was non-invasive. And not everybody with syncope or severe headache or some combination of those got a lumbar puncture. When they did, if they were comatose or stuporous, they often were just placed in a hospital bed and cared for with intravenous fluids and occasional blood pressure assessments with a sphygmomanometer, and maybe some wall oxygen if that was thought to be needed. But they had to awaken before most people would become interested in evaluating them.
Mm-hmm.
And there were people who were poorly responsive, who didn't get diagnosed because there wasn't a universal way to look for blood in the brain. There was data starting in the 50s and 60s that with impaired consciousness or a so-called high-grade subarachnoid hemorrhage, that the outcomes were poor and surgery was dangerous. So the controversy of the time was, do you do aggressive diagnosis and do you do early surgery? And it really was only in the late 70s and into the mid 80s that more aggressive diagnosis oriented and treatment oriented neurosurgeons began to say, hey, it's the same problem as a mild grade 1 subarachnoid hemorrhage or an asymptomatic aneurysm. You're not going to fix the problem and decrease the risk until you treat the lesion. And gradually it evolved that these people should be in an ICU, that we should do an early angiogram, and that they might need treatment for hydrocephalus, and that they might require much stricter blood pressure management and all the things in nutrition and airway protection that we now do.
Yeah, it's really changed so dramatically from those early days, and I think it always amazes me how far we've come. And I guess Hopkins is a good example where you've really the tools that were used in the initial management, the blood pressure cuff and the external ventricular drain, in many ways are tied to your institution.
Right. It's true. And I think that story exists for all the diseases that we now treat. Give me a 1 minute pause, will you?
Sure. All right. So I interrupted you when you were talking about some of the large hurdles in the early days. But one thing you had mentioned was there was no textbook on how to manage these patients. So
Right.
how did you come to a consensus about what to do?
I think we use the usual methods of medicine and medical inquiry and medical training. And I have stayed in the area of neurocritical care for my entire career because there were so many things that needed to be done and that there are so many interesting problems. I identified early on that we needed organized research and development. And I think there were, from a manpower perspective, maybe 5 or 6 questions. The first was what we were talking about, what to do with the critically ill neurologic patient as critical care or ICU care evolved from cardiopulmonary care and surgical trauma care. And the second was who is a legitimate patient, or what diseases and which specialties patients were appropriate for a neuro ICU. Third was what skills are mission critical. And I'd list a shortened neurological assessment of airway skills, ventilation skills, blood pressure support, arrhythmia diagnosis and management, nutritional support, understanding of coagulation and bleeding interventions, and then an understanding of wherever the evolving front was in all the neurodisease specific interventions. And the key ones were where nothing was available, but was evolving: cerebrovascular, infection and inflammatory diseases, which includes the nerve and muscle diseases, status epilepticus. Those would be some of the big areas where there needed to be skills. The next problem was how to share information about a new specialty, which was really your question. And then perhaps the final one was how to train others. My personal assessment of those 5 areas at Johns Hopkins was that if we were going to survive as a specialty, we needed something to teach other than general medical and surgical skills. We needed those skills, but we didn't have a lot to teach, so that there was a role for basic lab research. And I took the fellowship training that I had between medicine and neurology. And then after neurology, I did what's called a systems physiology fellowship, working in a ventilation and circulatory control lab that was run by a physiologist, Richard Treitzman. And we did molecular physiology on whole animal systems. And I was fortunate enough to working with Dr. Treitzman and a man named David Wilson, who was another physiologist, and a man named Raymond Kohler, who is now head of the Treitzman, the program Treitzman started, to have physiologists as both teachers and colleagues, and that matched well to ICU skills. And through their help, we had a series of multiple NIH grants over a 20-year period. And we started doing a 2-year fellowship with 1 year of clinical exposure and 1 year of lab exposure total, but both intertwined over a 2-year period. And I think that became critical to the legitimacy of the specialty, because we both exposed people to the problems that existed and the solutions of the time, but gave them a background in physiology, in both humans in the ICU and in animal physiology, diving deeper into mechanisms of regulation. And that served our trainees well. I was lucky enough to get a very nice scientific training starter grant from the Charles Dana Foundation, and have 20 years of support from them, which allowed for the trainees to have lab time. And then their work, more than anything else, set up some of the answers to the 5 questions I posed.
That's fantastic. And can we take one step back though? You mentioned that initially the neuro ICU was sort of a conditional ICU, and there was some resistance from our colleagues in the surgery realm and home critical care. And you spoke to some of these things that you said offered some legitimacy to what we were doing. So what was happening in Hopkins that really established the ICU as something that was going to stick around and give you the opportunity to train all these people who would then go out and sort of proselytize and spread neurocritical care throughout? How did that really gain a foothold?
Yeah. Well, you would think there should be, given, the 5 things that I described that we needed to evolve a specialty, that you could come up with a list of milestones that you might meet. But I think it didn't work quite that way. We didn't kill anybody.
That's a good start.
Right. That's always a good start. We met a need that was a bigger need outside of neurocritical care, which was to support and evolve 2 departments, neurosurgery and neurology, and a third partner department, anesthesia, which had the same training mission. So we helped them better do their mission. And when the individuals who oversee the yearly allocation of resources saw that those departments were robust and meeting their overall needs, we were moved out of the 4-bed unit. They allocated money to build a real 8-bed unit around patient needs. And that included glass but walled off areas so that individual patients could have a more quieter, controlled environment, which we didn't do well at in the 80s, but have eventually gotten there. And we had that as a home for about 6 or 7 years. And as the realization came across specialists and neurologists and neurosurgeons working in smaller communities that didn't have this resource, that for a small percentage of their patients, this resource was helpful. Then we started getting referrals, and we ended up with a 12-bed unit and another 4 or 5 step-down beds.
Yeah, So if you build it, they will come, I guess. There's
Right. And if the worst expectations of the naysayers are not realized, if um, uh, I was a trained neurologist who also was a boarded internist. Cecil Burrell was a trained anesthesiologist who was a boarded internist and had done a year of a general shock trauma fellowship. So between the two of us, we had, some degree of the core, what have become the core competencies of the specialty, and could begin to share that with others. And I am certain that there are things in our practice that we could have done better. So that's the opposite of, well, we didn't kill anybody, not obviously. But we did a good enough job so that one of the consumers of healthcare at Hopkins is faculty and family, and they come from all the departments, and they were happy with our care. Ski Lauer, seeing day in, day out trauma care at University of Maryland and at Washington Hospital Center, knew how important it was to be family centric and to meet the intellectual or emotional or both needs of the family of the patients you had. So we were perhaps a little more family friendly than some of the other ICUs. And I think that helped in acceptance as well.
That's really interesting. I think it seems in only recently, I think, are really embracing the role of the family in critical illness and family engagement and in recovery trajectories. And but that's very interesting that Ski Lauer recognized that back then, and that maybe made a large difference
in the 80s.
Yeah. And so you mentioned kind of some of the goals you set out, which if I summarize right, one was sort of to define what is neurocritical care, what are the illnesses that we should be taking care of, and who are the people that do it, and what are the competencies. Two is kind of how do we gather and share data, and three is a little bit like how do we train others to continue this. Take me through what are some of the achievements that you're really proud of, either of your own or your trainees that, as you said, have gone on to answer many of these questions. What are the things looking back that you think have made the largest contributions?
Sure. Well, maybe the thing that I'm most proud of is that almost all of the trainees during my leadership time, and since then under Mark Mirsky, Romer Geocaden, and Jose Suarez, each of whom I had a part in their training, have stayed in neurocritical care and have committed to this mission and these 4 or 5 main questions. I'm equally proud of trainees who aren't physicians, who have oriented themselves to the critical care model, that it's a polyprofessional. And the story about Ski Lauer and families projects into a PhD, Lourdes Carhuapoma, who's studying family interactions and how can we provide families with better information so they make informed decisions in the ICU. Unfortunately, she's deceased. A woman named Rebecca Rubinoff, who devoted her academic life to the nutrition of neurocritical care patients. There have been several pharmacists who have become neurocritical care leaders. So I think the people who have carried on the interest is probably the single most important contribution that Dr. Burrell and Skielauer and myself, with the support of Don Long, Guy McCann, Chip Moses, and the hospital catalyzed.
Mm-hmm. Is there a particular case that sticks with you when you think back over all the years, that I think we probably all have certain cases that we really remember or we really get involved with? Is there one that really is at the forefront of your mind when you look back at your career?
Yeah. Names will be excluded to
Of
protect.
course, yeah.
Um,
I figure the sample size is probably large enough at this point that we can have some anonymity in here.
Right. There are maybe three that come to mind. The first one was a young man with an incurable disease who had a clivus chordoma, and tested our skills in making care family centric around the region, the areas that we've talked about. The second one would be an idiopathic subarachnoid hemorrhage patient who had he was a diabetic. He probably had microvascular disease and had a periventricular bleeding point, and filled his ventricles entirely with blood, and was comatose for a couple of weeks. And I was challenged by many individuals as to why do we keep putting interventricular drains into this gentleman? And this was pre-thrombolytics. Mm-hmm. After about 10 drains, he finally had a functioning CSF flow system again. Woke up and went back to work as a very important and productive salesperson for a major company that had a national presence. And eventually, when he retired, became a patient advocate and an NCCU volunteer.
Oh, wow.
And convinced me that number one, blood in the ventricular system is bad, and two, if you can get rid of it, maybe patients will survive, even though what I was taught in residency is if you have a grade 4 interventricular hemorrhage, you're dead. So that helped with what was my belief system at the time, that nihilism isn't good.
Right.
And maybe a third one is a young woman who was a reporter who came in status epilepticus, and that was treated. Although, we learned that we had already known, but we applied that just because someone doesn't have motor concomitants of seizure, that they may still be seizing. So we got her situation under control, but she didn't wake up for a month. And what do you do with a 25-year-old who's comatose, whose disease you don't understand? You don't know why she was seizing. We had some hypotheticals, Um, and most of the senior people in the hospital um, suggested that again things were in a severe situation, that she showed no improvement, and that we probably should be offering supportive care or withdrawing care, as she needed ventilation for 3.5 weeks, close to a month. It looked like I had established myself in the treatment area in the area of viral encephalitis. It turned out we eventually found out she had lymphocytic choriomeningitis.
Mm.
I had co-written several papers on the natural history of undiagnosed viral meningitis. And I took the non-nihilistic perspective that she didn't have herpes, which I had been involved in developing the first antiviral that was successfully able to at least stop the progression of herpes encephalitis. And I pointed out to my elders that in the observed prognosis in a case series that we had published in JAMA, that the people with viral encephalitis who did the best were those that we weren't smart enough to diagnose.
Right, right.
And I shared the same information with the family. And it was unusual to get MRIs on critically ill patients, but we got several MRIs and showed there was no sign of evolving injury to cortex or white matter from encephalitis. And I took the unpopular view that it in a 25-year-old, it was okay to support her for a little while longer and see if she woke up. She did wake up. She over a year returned to normal cognitive function, and now is a mother with children, and is a productive member of society as a investment banker.
Wow. Well, that's a great story, and I think in many ways it summarizes what I think it means to be a neurointensivist as I get further into this field, which is sort of having a lot of humility when it comes to prognosis and uncertainty around it, and fighting against nihilism. I think that is those are core competencies for a neurointensivist.
I agree completely, and I think you stated it very nicely.
Maybe we could go back to that second case and transition a little bit to talking about intracerebral hemorrhage and intraventricular hemorrhage, because it struck me that in that case, perhaps this was an inspiration for further work that you did and that led to the CLEAR-3 trial and use of thrombolytics. And maybe we could talk a little bit about these problems and some of the exciting advances that are happening now. So CLEAR-3, on which you were the PI, for those listening, was unfortunately a negative trial of thrombolytic therapy for intraventricular hemorrhage. I'm interested to talk to you about this because one of the things I think is so fascinating about the study is that there were various endpoints, and one of them was clearance of over 80% of the hemorrhage, and in that subgroup of patients, they seem to actually do better. And I think we always have to be careful about subgroup analyses. But I'm kind of with you when you were describing that second patient. I think intraventricular hemorrhage is just a bad thing to have, and I think clearance is probably good. But what have you learned from CLEAR-3, and how do you put that into action clinically? And where do we go from here with the problem of intraventricular hemorrhage?
Sure. A great series of questions. I would clarify maybe one point in
Please.
your question. Clear 3 represents the fourth or fifth in a series of trials we did. I'd call it neutral, not negative. When both of us were in medical school, trials were either positive or negative. That's a Wall Street Journal vision of randomized clinical trials, and negative in that it didn't produce a blockbuster drug.
Right.
Okay, but neutral with a point estimate of benefit is how I would probably characterize it. And then when you put it into context of we didn't have primary treatments for really any neurologic disease in the 1970s, and by the 80s, when we started neurocritical care, there were few. Acyclovir for herpes encephalitis, some of the patients of which didn't need a neurocritical care unit, may be a good example of one of the firsts. So the Clear story evolved from patients like the one I described. A neurosurgery resident who became a neurocritical care fellow and now teaches neurosurgery residents at Johns Hopkins, Neil Naff, called me in the middle of the night and said he had an ICH patient with obstructive IVH, and he'd put in 2 ventricular drains as well, each one clotted and couldn't drain. And the patient was hypertensive and appeared to have a Cushing's reflex. And would it be okay if he squirted in a little bit of urokinase when he put in the next drain? And he said, otherwise, I think this guy's going to die. And I said, okay, makes sense. Try it. And I came in the next morning, and the man's blood pressure was under control. And we re-scanned him, and he no longer had a locked ventricular system. He'd had some thrombolysis, and there was a little bit of CSF that was draining. So we started doing that in an organized way. Neil Naff and Michael Williams, another trainee who's now a professor of neurology and runs the hydrocephalus program at the University of Washington, did all the hard work of defining a protocol, getting an FDA IND, and we started a low-dose urokinase program, which, when urokinase was taken off the market for some production problems and contamination, and the production problems switched over to TPA. And we created a case series. And this is important, I think, in the rise of clinical trials in neurocritical care. When you don't have a treatment, a primary treatment, you can do single arm studies in which you expose all patients to treatment if it can be legitimately shown that it's in the benefit of that patient to be exposed. We did that, and we showed we had predictive algorithms that all of these patients died. So the clinical wisdom in the story I told you was more than wisdom. It had pragmatic data behind it. And we showed that 80% would live in this single arm study. And that became the predicate for an FDA orphan drug application, which required 5 submissions in order to get funded. And then it required special privileges from the FDA to switch from, we wrote it about urokinase, but urokinase was prohibited from being used for 2 years. So we switched it to TPA and started first the safety trial, in which we learned a lot about how EVDs can create brain bleeding and make it worse. The interaction between the treatment and the EVD, and how to manage that situation, and showed that it was safer than doing nothing. And then some dose finding studies, and then finally Clear 3. Now, there have been 4 or 5 registries since then, and a neurointensivist in Erlangen, Joji Kuramatsu, has put together all that data with the Clear 3 data, and with the help of Wendy Zi. And their paper in JAMA Open is now 1,500 patients. And although it's not a randomized controlled trial, it's what's called an individual patient analysis or meta-analysis, but patient by patient, not trial by trial. Mm-hmm. A lot of technical distinctions there. And it shows a clear, statistically significant 10% absolute benefit in the proportion of patients that reach a rank in 0 to 3. I think there'll be a Clear 4 trial eventually. And it also shows some interesting things. One thing that I thought was obvious, it turns out not. I thought it would only work when there was a small ICH, appears to work when there are big ICHs as well. And there's a benefit in that assessment of treating earlier.
Got it. How, if I can ask, if as you envision Clear 4, how would it distinguish itself from Clear 3 potentially? What would you do differently?
We learned in Clear, in the Clear 2, the dose dose finding pharmacokinetic study, and Clear 3, and I believe it's in others' data as well, that we didn't fully understand drug delivery when we went through this program, and that when there's a lot of blood in the ventricular system, you may have to deliver blood and drug in more than one place. Wendy Zi has published some nice studies with Holly Hinson, who now was in Oregon and now is a leader in neurocritical care at UCSF, and has a research program of her own. They looked at bilateral catheters, and we think putting one catheter into the clot, like you do in MISTY, and one to drain the CSF, and having more than one place to deliver TPA, both gets the clot out faster and gets more of it out. And I think that's probably the thing that would distinguish a Clear 4, and that happens to be our plan for that program.
Any lessons from the early drain trial in subarachnoid hemorrhage using lumbar drains that can be applied to intracerebral hemorrhage with IVH, in your opinion?
Yeah. I mean, the single biggest lesson is things you don't look for, you don't see. And a lot of us went through life saying if the ventricle is clear, we got all the blood out, ignoring the basic anatomic fact that the lumbar CSF space has half of the CSF. And if you don't see it on a CT scan, you don't see that space on a CT scan, so you don't know if there's blood there or not. We'd known for a long time that after subarachnoid hemorrhage, you can have blood products in the lumbar space for long periods of time. The group in Erlangen has pioneered in draining that space. We know from animal models that blood in the brain and blood around the brain and blood degradation products, whether they're degraded iron, degraded porphyrin heme, or degraded hemoglobin, all create an inflammatory problem for brain tissues. And they've clearly shown that recovery and perhaps the likelihood of fibrosis in the CSF space and hydrocephalus are improved by drainage. That said, it's a high-skill procedure that not all people do well, that potentially exposes patients to bacterial meningitis, and done improperly exposes patients to compartment syndrome and herniation. It needs it should be tested, evolved, and a procedure developed that people outside of Erlangen can easily do.
Mm-hmm. Yeah, I wonder, I think a lot of centers have started placing more lumbar drains in subarachnoid hemorrhage patients, and whether we may see some indication creep over time into the ICH population.
I hope we do. I think there are two basic parts to doing it correctly. You have to have the lumbar catheter and the ventricular catheter in place, and you have to demonstrate that there's been enough ventricular and extraventricular blood removal so that you're not going to develop a compartment syndrome, and that the pressures are stable and equal between the lumbar and cranial spaces. And then you have to have really good antisepsis, including great nursing to make sure patient doesn't expose themselves to infection by partially pulling the drain out.
Agreed. Well, maybe we could move on and talk a little bit about MISTY-3 and then finish up. MISTY-3, of course, you were the PI on another neutral study, but one we've learned so much from, I think, and right now we're sort of all eagerly awaiting the results from the ENRICH trial, which was a different type of procedure, a minimally invasive procedure for ICH. But again, I think a lot of people have sort of seen a corollary between the ischemic stroke story and the ICH story, that we have some idea, and I think MISTY-3 has helped us with this, of figuring out what is a target outcome for the procedure, which we've now learned from MISTY-3 may be less than 15 milliliters generally. And now we need to find new ways to actually achieve that. I guess, where do you see all this going? And if you could talk a little bit maybe also about timing of the procedure. So you mentioned in IVH that timing seems to be important. Some people have criticized MISTY-3 because it did take some time using that procedure to actually get the hematoma down to its target. What do you see as the future of minimally invasive surgery for ICH?
Good. That's only 6 questions and encapsulizes 30 years of my life. So I actually think those are great questions, and I think they're the right questions. MISTY, the MISTY series of studies, and there were 3, a open label set of studies organized by Ricardo Carhuapoma, a MISTI 2 that was a dose finding, and then a MISTI 3, which I did with Assam Awad and Wendy Zi and Mario Zuccarello, among many others. And both MISTI 2 and MISTI 3 and Enrich all demonstrate that what the public health epidemiology studies show, that you're going to do much better if you have a small hematoma than a large one. And what these 3 surgical trials show is that you don't have to judge small hematoma by the day you present with the bleed. It can be in the first few days after the bleed. The next question is there a time limit? And when we look at our data, we find that it doesn't matter whether you reduce the hematoma on day 1 or day 2, or even into day 3. You can do trial meta-analyses, and they are equivocal. Some show no effective time, and others, pushed by people who want to study time only, suggest that there could be. I say this is an area where we don't know and we should find out. It's very important to public health. Not all patients are going to get to a neurocritical care unit and a neurosurgeon in day 1. And if there's benefit on day 2 and perhaps into day 3 or 4, we should know about that. Most of the extrapolations suggest that there is benefit. And in the recent World Intracranial Hemorrhage conference, I actually asked this question of the Enrich people who are advocates for early, and there are good reasons. And they say, yes, their surgery does produce benefit on the second day. And it's the first time I've heard that group begin to address this problem. So we need to answer that question, and that's one that we need to answer in a MISTI 4. I think the other question that is important to answer directly, or the primary one, is to show that taking the hematoma out does make a difference beyond mortality. I'll point out that if neurocritical care was cancer, then CLEAR was a positive study.
Mm-hmm.
It was a positive study.
I bring this up all the time on rounds. We hold our trials to a much higher standard than any other field, right?
And it may be a mistake, and some of that comes from a whole paternalistic nihilism of, we know what would be good for the patients.
Mm-hmm.
In MISTI 3, we asked the patients who survived, including the rank and 4s and 5s, how did they feel about their situation? Half of the rank and 5s are happy with their situation. Is it true that you should be unhappy if you need total care and support? I would think so today, and I'm sure most people who don't need that think so. But half of the patients living in that situation think otherwise. You know, what their spouses think and what burden is on the family, those are other questions that need to be answered. So I think the big question in the next trial is still the question, is doing something better than doing nothing? Enrich, to my mind, didn't answer that. To bring the conversation around, the paper is at the New England Journal of Medicine. Alan Roper will probably be the determining editor for whether or not it's published there. I think it's going to be very important for us to look at the data. Enrich is a Bayesian trial. Bayesian designs are usually used for phase 2 dose finding, treatment calibrating studies. There is an indication, a strong indication of benefit for one subgroup, the lobar hematomas. There's no and possibly negative benefit for deep. In MISTY, we saw benefit in the deep subgroup. Point estimates of benefit. A point estimate is not for benefit in rich. So there's much to be digested there. We've taken the MISTY-3 data, and there's a nice paper in neurology now doing a Bayesian analysis on MISTY-3 data. It's positive too. We have to, if you're going to use evidence to guide therapy, reject the null hypothesis. And the enrich trial design and the sample size only suggests there's benefit. A second Bayesian design to show that the enriched patients aren't different from doing nothing has not been done to reject the null hypothesis. That requires a substantially higher number. There are only 100 patients in the lobar hematoma category exposed to treatment compared to the, I think, 150 controls that they have. So we'll see what others say about whether or not this is guideline changing. I don't think it is. I think it's confirming of the messages that are in MISTY-2 and MISTY-3.
Mm-hmm. You mentioned some of the discordance maybe between MISTY-3 and what we've learned about enrich so far in terms of locations. And do you think ultimately we'll be talking about maybe different types of procedures for different hematoma locations?
So the good thing about MISTY-3 is it's focused the investigative world on a definition of a surgical task and making the hematoma smaller. And if you look at the number one factor that's predictive of poor outcome, it's hematoma size, not location. Location is about 3 or 4 in a hierarchical assessment. That's very bothersome to people like us who trained as a neurologist to learn, what each location in the brain does and what are bad locations for lesions. But we have to manage both factors in the care of ICH patients. And volume reduction, which has been accepted by almost everybody designing trials and by almost every neurosurgeon as the goal for the task, I think that should ideally remain the main design element in a trial. Whether you use a Volkswagen, like a small, usually not damaging EVD catheter, or a large brain path trocar that has a 16 millimeter profile, which may be damaging when you try to insert it into the deep basal ganglia that have many, many small penetrating arteries. Whether one is better than another, I think should be judged by the outcome of the patients, and the intermediate variable is the surgical task. There will always be a better tool, whether it's a better tool for intensivists or surgeons. And I think we shouldn't get distracted by the fact that new tools will develop. We need to test, does the surgery do the task, and did doing the task alter the outcome?
Well, that's great. At the end of this, with each of our guests, we have some kind of quick hit questions to get a little more insight into how you think as an intensivist and your life outside the ICU. Do you have any passions or hobbies outside of neurology?
Yeah. I like skiing. I like tennis. I like swimming. I like traveling. I like cooking. I like eating and cooking. And I enjoy hiking in the outdoors.
Great. You mentioned you'd stayed in neurology and neurocritical care throughout your career, but if you had to pick a different specialty, what other specialty would you have liked to have attempted?
Um, I've always said I'd like to be a veterinarian because it's even more challenging than neurocritical care. You get the whole body of an animal, and you get a bunch of different kinds of animals, including us human animals.
Yeah. And what specialty would you not like to do?
Um, well, um, I don't know. There isn't any bad specialty. I'm not. I don't think I'm temperamentally cut out to be a pediatrician. I'm probably not temperamentally cut out to be a psychiatrist or a psychologist. I probably don't have the patience for either of those specialties.
Got it. Is there a sound or smell in the ICU that you really like, or that brings a sense of home for you?
Yeah, quiet.
And is there a sound or smell in the ICU that you really hate?
Um, I don't love betadine.
It's a good one. And then just to wrap up our conversation, um, what advice would you give to a fellow who's about to graduate?
Um, there are more unsolved problems than there are solved problems. Realize that we don't know the answer most of the time. And that environment can make for a very solid set of opportunities, a solid career to improve where we are today.
Great. Well, thank you.
I have one more statement in that area.
Please, please.
And if you don't do it, no one will.
That's right. Well, that's so funny. Human Kamel, I remember when I was trying to pick my kind of career path as a fellow, he had similar advice, and he said, well, if not you, who?
Right.
Yeah. Well, thank you so much for coming on the podcast. You've teased us a little bit with Clear 4 and Misty 4. We're really excited to see where we're going in ICH and IVH. I think it's a really exciting time to be part of our field, and I'm very appreciative to all that you've contributed to it, and it's helping us take better care of our patients, and also giving us therapeutic options that fight the nihilism that you mentioned earlier. So thank you so much for your time and all your work, and hopefully we can meet up for brunch in Baltimore one day.
It's wonderful to talk to you, Nick, and I think you're doing some great things in important areas of training and pain control that will benefit all of us.
All right. Thank you, Dr. Hanley. So this wraps up the Neurocritical Care podcast perspective series with Dr. Daniel Hanley. This will be available anywhere you get your podcasts, including Spotify and the Apple Store, and the Neurocritical Care website, and CME are available. Thanks again, Dr. Hanley.
Bye, Nick.
Bye.